Hello, I'm Nicolò Battisti. I'm a consultant medical oncologist in the breast unit of the Royal Marsden Private Care, and I'm the clinical lead of the Senior Adult Oncology program. In this video, you're going to learn about the importance of a broader multidisciplinary approach in the care of older patients with cancer and what the field of geriatric oncology is about. So cancer is predominantly a disease of older patients. Approximately 50% of the diagnosis from cancer and 70% of the mortality from cancer occur over the age of 65. For example, in the States, cancer registry data suggests that between 1975 and 2040, there will be a 17-fold increase in the burden of cancer in people over the age of 85, as opposed to a 4-fold increase in people over the age of 65. And this is the reason why older people should really be a priority for clinical implementation efforts, for education in oncology, for research in oncology, and also for national cancer control plans. Unfortunately, much of the evidence that I'm using every day to inform my treatment recommendation with patients and the families is typically generated in much younger and healthier patient population. This is because older patients are typically severely underrepresented in clinical trials in oncology. In 1999, for example, some research documented that only 25% of the patients recruited in large oncology registration studies were older, over the age of 65, as opposed to more than 60% of older cancer patient population in the States. And this means that essentially the applicability of the evidence that I have to inform my discussion with patients is far more limited when it comes to managing cancer in real-world older patients. Inevitably, this leads to treatment variation, for example, that we have documented here in England and Wales a few years ago across many different trusts, showing that the variation in the use of systemic, so drug anti-cancer treatment, is far broader in older age groups as opposed to younger age groups. And while this might be related to some variation in the population of patients looked after by different trusts, this might also suggest some degree of overtreatment and undertreatment in this patient population. The challenges of managing cancer in older patients are related to the fact that, for example, there is a gradual decline in the function of multiple organs and systems with the aging process. For example, let's think about the cardiovascular system, or again the digestive system, the liver, the kidney, whose function typically declines as we all age, but also related to the fact that there is an increasing prevalence of additional problems with the aging process, for example, functional impairment, but also cognitive problems, polypharmacy, malnutrition, lack of social support and activity, quality of life concerns that really challenge and make the management of cancer in older patients particularly complex. And these are very frequent concerns that we have to address in our oncology clinics every day when we look after older people with cancer. Patients typically would be worried about the impact of cancer treatment on the management of other medical conditions, for example, cardiovascular disease again, or diabetes, but also the impact of cancer treatment on fatigue, energy levels, the risk of falling, the nutritional support that this patient may have, the weight, but also, for example, the potential interaction of cancer treatment with other medications that they may be taking as part of the management of other medical conditions. So a critical question for older patients with cancer is how will I tolerate the treatment? When it comes to older patients with cancer, there is a significant risk of undertreating, for example, this patient population. And this may mean, for example, giving these patients less effective suboptimal anti-cancer treatment, whereas actually they could benefit from an escalated and more effective treatment approach, but also not providing them with additional interventions tackling all these additional problems they may have alongside the cancer, for example, malnutrition, functional impairment, polypharmacy, and so on. There is also a risk of overtreating this patient population, for example, with treatment options that may be less meaningful and not able to actually improve the symptom control or the survival outcomes from the cancer. But also overtreating them by providing them with treatment that are too strong, too toxic, whereas they could benefit from a gentler, de-escalated treatment approach. So, for example, comprehensive genetic assessment is a key solution to these challenges. CGA is something that our field, the oncology field, has learned over a number of years at least 20 years from our geriatrician colleagues, is a diagnostic and therapeutic process looking at evaluating and addressing these critical healthcare domains for our older patients with cancer. These domains are again physical performance and functional status, nutrition, geriatric syndrome, hearing, vision, quality of life, polypharmacy, cognition, social support and activity, with validated tools also in the oncology fields, and critically with interventions that happen typically in a multidisciplinary setting. For some of these interventions, I'm absolutely expert about, being a medical oncologist. I can adapt anti-cancer treatment plans where this is evidence-based, safe, appropriate. But for many of these interventions, I need to work with a much broader MDT, including, for example, geriatricians where available, but also physiotherapists, occupational therapists, dietitians, nurses, and primary practice, but also other specialists. For example, when it comes to functional impairment, revision of devices can make the patient more autonomous and independent in the community, but also fall prevention discussions, balance training to minimize as much as possible the risk of falls in this patient population, and supporting them in exercising where they actually feel able to do so, and this is beneficial. When it comes to malnutrition, for example, we can advise patients on oral nutritional supplements to support their nutritional status, but also assessing any support that they may require with meal preparation, and empower their caregiver to make sure that they are looked after also from that point of view. When it comes to comorbidities, a much closer interaction with primary care physicians, GPs, and other specialists to make sure that we are not disrupting the management of other comorbidities that this patient may have with our cancer treatments. When it comes to polypharmacy, certainly an important aspect is deprescribing potentially inappropriate medication that these patients may no longer require in the context of a cancer diagnosis, but also prescribing potentially appropriate medications that may actually benefit from in the context of their cancer and its treatment. Or again, assessing the adherence also to non-oncologic treatments that might make, for example, the cancer treatment less safe or increase the risk of complication on cancer treatments. When it comes to cognition, it's important that we, as oncologists, reduce as much as possible the complexity of our treatment so that they can cope with this without any risk of harms and to benefit from it fully. But also we assess cognitive status to assess whether, for example, the patient has capacity to consent for our cancer treatment. And finally, social support and activity is something that we can support patients with, for example, transport assistant, nursing or home health, and again with supporting caregivers where this is required. When we, for example, looked at our own patient experience, those patients treated by our senior adult oncology program a couple of years ago, we found that, for example, they have as key concerns the family and their caregivers in more than 60% of patients, and their quality of life and independence in more than 40% of patients. And this is really something that we can assess for our patients with a simple question, what matters to you, which is typically included in our baseline assessments and questionnaire that our patients complete ahead of attending our oncology clinics. This is something that we can use as oncologists to frame our discussions with patients around the pros and cons of specific cancer treatment in the context of also additional evaluation that can allow us to understand, one, what is the prognosis of the patient in the context of the cancer, with, for example, specific tools that are available online, such as ePrognosis, a repository of prognostic indices that we can use in various healthcare settings, in patients, outpatients, nursing homes, or again, community, to understand the risk of mortality of that person at a number of years, which is helpful for us to understand whether pursuing a specific cancer treatment is really meaningful or not. But second, also to predict the risk of complications of cancer treatments. This is something that we can do with, for example, what we call chemotherapy toxicity prediction tools. And again, look at lab values, the type of cancer that patients might be considered for, but also geriatric domains, again, cognition, functional status, nutritional status, to predict the risk of severe, what we call grade 3-5 toxicities on chemotherapy. So toxicities, complications requiring hospitalization. And third, predicting also what is the benefits associated with specific cancer treatment options. For example, with the Bridging the Age Gap decision tool, which is available online, which allows us to predict the benefits associated with chemotherapy after surgery for patients with early-stage breast cancer, or the benefits of surgery versus primary endocrine therapy, again for patients with operable breast cancer, on the basis not only of the breast cancer characteristics, but also on the basis of geriatric domains. So these are all assessments that I can use in my clinics every day to make much more accurate and informed and shared decisions with my older patient with cancer.